Welcome back to Taking Charge of My Cancer podcast, episode 75. It's my honor to have as a guest Dr. David Iglesias. He serves as the chief of the University of Florida Division of Gynecologic Oncology. A proud gator, he attended UF for his undergrad studies, medical school, and resident in obstetrics and gynecology. Following his residency, he completed a fellowship in gynecology oncology in MD Anderson in Houston, Texas, where he also earned his master's in science in biomedical science. Prior to UF Health, he was an associate professor of gynecologic oncology at Virginia Tech Carilion School of Medicine in Carilion, Roanoke Memorial Hospital. He's a board certified in both obstetrics and gynecologic oncology. He also is an active member of the Society of Gynecologic Oncologists, the Mid-Atlantic Gynecology Oncology Society, and the Felix Rutledge Society. He enjoys spending time listening to his patients, forming relationships with them and their families, and helping them better understand and navigate often difficult clinic scenarios. His goal is to provide a supportive and comfortable environment where patients can share their story and they can work together to build a comprehensive, personalized care plan that incorporates the most up-to-date, evidence-based treatments with maximized quality of life. Through his career, he had worked with other physicians, basic science, and epidemiologists investigating the genetic, clinical, and epidemiological risk factors to contribute to the development of gynecological cancers, better understand the underlying mechanisms of this disease and how this information can be used in clinical practice to help treat patients and prevent disease. Recently, his research focus has been improving patient access to leading-edge clinical trials for patients with advanced or recurrent ovarian, endometrial, and cervical cancers. He also has an interest in strategies to improve patient education and cancer survivorship. And in his free time, he enjoys hiking, backpacking, reading, and spending time with his family. So I can continue on and on. Amazing for all the work that you've been doing, and it's an honor to have you in here with me today.
Well, thanks to you for the invitation. I really appreciate that. I'm excited to be here.
Great. So tell us about your role, and did you always were planning to do this?
Sure. Yeah, I'm currently serving as the division chief for gynecologic oncology here at UF Health in Gainesville. I just started the position last July 2023 after being in Virginia for about 9 years. And I'm really excited to be back. As you mentioned, I did a lot of my training at the University of Florida. I spent a good portion of my life in Gainesville from undergrad and medical school and residency before I went off to do fellowship in Texas. And so my role here has been basically to help grow the division, both clinically and academically and educationally, to kind of really focus on that kind of tripartite mission of educating our next, our new learners and trainees, and also developing research programs, but also really providing comprehensive care for women who are faced with a cancer diagnosis, particularly gynecologic cancers. So that's really what my role is. As far as whether this is something I've always planned on doing, I think, as I'm sure a lot of people who've been on this podcast have said, that over time our kind of our decision about how we go into medicine and where we end up, I think, has been an evolution. I think that different parts of our lives can influence how we go into different directions, and I think that was probably the same thing for me. I feel like, as far as back as I can remember, I've always wanted to be a physician. I always wanted to be a doctor and take care of patients and really be in front of cutting edge science and be involved with that. So that's really where my life goal has always been. As far as being a GYN oncologist, that's something that kind of came later in the game. When I was starting medical school, I really didn't have a clear idea of what I wanted to do. I mean, I was pretty open to a lot of different options. I felt like I had an aptitude and wanted to do something procedural, so something in the surgical subspecialties or a surgical field of some kind. And I had an interest in oncology and in cancer care, more of just a kind of academic interest. And so, as I went through my rotations in my third year, I was really kind of looking into things like, neurology or surgical oncology or something along those lines. And really wasn't my first day of my third year of medical school. I did my OBGYN rotation first. That was the first one I did. And my first day of my first year of the third year, when we started clinical rotation, was with the GYN oncologist in their clinic. And I was so like just impressed by the scope of what they did, and like, all they did the chemotherapy, they focused on surgical treatments and post-operative care, and worked with radiation oncologists to develop treatment plans. And I just thought it was such a great and kind of broad field, but still focused in one group of patients. And so really I just kind of fell in love with it then. And then really over the course of the year, that just kind of got more solidified as I looked at other options as well, and really kind of had great mentors and who were GYN oncologists here who really helped kind of form my career goals that way. So it was kind of a late addition, but then I think it just made sense. It's one of those things you kind of find something which just kind of clicks and then you go with it.
Yeah.
So that's kind of how it fell into me.
Yeah, and it's super interesting because I think that very few of my guests that are in medical field had, and not just necessarily medical field, a lot of people really didn't think that they were going to end up doing this path of oncology for either from the nutritionist standpoint, physical therapy, surgery, whatever it is. And I think, including myself, right? I've been a PT for many years, and I did orthopedic sports medicine for a long time. And when this just kind of like, I start this path and I'm like, it's such a great field that I'm so glad I'm able to be part of it and able to advocate for patients and able to create this to educate patients. And I think that, things happens for a reason in life, right? And all of us end up in this path, and it's just so rewarding, right? So it is really like so great to be able to see a smile on a patient. It's great to see a smile on any patient, but then in particular when they're going through so much, that really
Yeah,
makes a difference.
I agree. I think it's just very fulfilling. I really enjoy kind of developing those kind of long-term or longitudinal relationships with patients. And obviously we're sometimes confronted with difficult decisions and complex treatment planning, and a lot of kind of heavy, both physically and emotionally heavy topics. And I really just enjoy kind of working with patients and their families and support teams kind of through some of those difficult decisions. And I like helping kind of navigate, what may seem like extremely overwhelming things, which they are overwhelming sometimes, but helping it make hopefully a little bit easier for patients and their families to help navigate that, and come up with rational treatment plans that make sense for each patient and like their specific scenario.
Yeah, perfect. So what are some effects of surgeries that you perform that affect, some of the patients?
Sure. Yeah. So just a little brief summary. I mean, I do a lot of surgery. Most of my job is doing surgery for cancer patients for female cancers, so uterine and ovarian and cervical cancer, and vulvar cancer. And so, as you can imagine, some of these cancers and some of these surgeries can be complex, and they can cause both physical and sometimes psychological changes, and sometimes can impact quality of life in ways that maybe not as apparent at first. So we do a lot of surgery, hysterectomies, ovaries. We sometimes remove portions of the skin of the vulva on the outside of the vagina, and sometimes parts of the vagina, which can have an impact on things like bladder and bowel function, sexual health, pelvic pain, pelvic floor disorders of different types, and can also have a broader impact on things like loss of hormones, and especially in premenopausal women who kind of have an abrupt change in hormonal, makeup and status, and menopausal status. And so that can have some kind of impacts on kind of the short term, things like hot flashes and other hormone related changes, but also kind of long-term effects like bone health, cardiovascular health, neurologic health. These are all things that we have to consider as we talk with patients through what change their body might go through.
Great. And sometimes I really love that you talk to patients about all this. Sometimes, you can have patients are already scared, they're overwhelmed. The only thing in their mind is I have cancer and I'm gonna die, right? And they come and then it's like, okay, what is it that we're gonna do? And then you just have to put on the table the different options, right? And everything you tell them, they only gonna remember one thing out of all that because they're so overwhelmed. But it is really good for the surgeons to really explain in detail this is what happened, or maybe write something for the patient, or like, this is what you're gonna have, and then you can have something to share with your significant other or your family. And sometimes I ask patients, well, what did the doctor say? I really don't remember what they say because it's just so overwhelming. It's so new information to them. So it's great to explain some of those things to them and then just make them to be their own advocacy, right? So they will pick and choose if they want to do that or not, right? Based on
Right.
whatever
Yeah.
options you give them.
Yeah, I think it's very, it's a thing that we have to be very sensitive to in the sense that patients when they're told they're have a diagnosis of a cancer, I mean that's obviously one of the only things they'll hear in the whole visit, and it can be overwhelming, and I'm sure comes with a lot of fear, anxiety, the unknown, and so I've seen patients kind of go a lot of different ways with that. Some will be like just anything it takes, just do anything possible, and some will be more kind of introspective and a bit more deliberate about things as far as the decision. So as a surgeon, the physician who's taking care of these patients, I think we have to kind of be thoughtful about I try to anticipate the questions they might have, try to anticipate some of the fears and concerns that they may have expressed in the past, or other patients I've had interactions with have expressed, and try to kind of answer some of the questions even before they know to ask them. Like I try to bring up some common topics that people have questions about, and then I'm always open to kind of having other visits, or phone calls to follow up, if they have friends or family that are involved in their healthcare decision making, or their support team, if they need follow-up conversations just to go through things. It's always better. I always tell patients it's better to have a couple set of ears to listen to these conversations and make these decisions with them. Just because it's so easy to forget, there's so much stuff, I do this every day, and and so it's not new to me, but that's the first time this person's hearing this. And so it's just hard.
If you can give 3 valuable tips for our cancer patients, what that will be?
Yeah, I think, that's a good one. I think that I always tell patients that when they're going through either surgical treatment or chemotherapy or radiation treatment afterwards, is just kind of really try to get a good understanding of what the changes their body is going through, and really kind of try and keep, either a diary or a log of some kind, so they're aware of kind of what their body is doing and how they're feeling. And that's important as they go through the treatment, because sometimes it can highlight areas that we might be able to improve upon. There are some, potential side effects of treatment that we might be able to mitigate, if they're having these side effects. Sometimes it could be, a common example, for example, we give chemotherapy for some of our ovarian cancer patients, and they're on chemotherapy that can cause some numbness and tingling in their fingers, or toes, and neuropathy. And so I've had plenty of patients in the past tell me, well, I just didn't want to affect my treatment plan, but these could be potentially long-term consequences and permanent consequences of therapy. And if I know about that information during the treatment, doesn't mean I'm going to stop the treatment, just means I might have to modify it, and, do some other strategies to help decrease the chances of that becoming permanent, or, different supportive methods we use to help hopefully reduce that being long-term impact on the patient. So, I think number one is just kind of be aware of the changes your body are going through, and be also an advocate for yourself. Be very vocal with your oncologist, whoever your treating physician is, and your team, just to kind of say, this is what I'm going through. Is it normal? Is it not normal? What's changing, and how do we navigate some of this? So that's probably one of the main things, especially for patients on treatment. Before you even begin treatment, or while you're going through diagnosis, I always tell patients it's good to kind of establish like who your support team will be. Like it's, like with anything in life, it's easy to go through it with a good support system in place. So for those who have benefit of family or close friends, or either members of their church or other social groups, just developing a good support team, I think is important. Just helps kind of, especially those difficult times when you might not be feeling well, or you just need someone else to be there to listen, or even drive you to a visit or something like that. I think that's really important for patients. And then lastly, just, kind of have a good understanding of your family's history. A lot of times patients, it's not very common to be talking about these topics during Thanksgiving dinner. So just be aware of what your family's history is, especially when you're newly diagnosed with cancer, and then also be, willing and open to talking about your own, journey with family members, because you never know how that might help them make health and life decisions regarding their own care in the future. So those are the big three.
Okay. Do you ask patients about like their bladder, bowel, and sexual function, which you kind of mentioned already, like you already talked to them ahead of the game, but if they're coming on treatment after surgery or follow-ups, that's usually those three things you ask about it?
Yeah, I pretty much ask that with every visit, even after they're done with all their treatments and they're just doing surveillance follow-up visits, just because it's such a big factor in just kind of overall general health and survivorship. And and sometimes it can be a sign of a cancer recurrence. Occasionally, if they've had a change in their bladder bowel function, or new vaginal bleeding, or vaginal pain, or pain with intercourse, things like that. So I usually will ask those questions as part of my routine follow-up visit, on every visit, essentially. Yeah, it's, I think, an important topic to bring up patients.
And if they say yes to any of that, do you usually recommend pelvic health floor therapy?
Yeah, I think that's a very valuable resource. I mean, I think that, and unfortunately, it's an underutilized resource that I feel like we should do better about, recommending pelvic floor physical therapy. I know that it's used a lot in patients with pelvic floor dysfunction, or, urogynecologic symptoms, bladder incontinence, prolapse. And, I think we don't utilize it as much as we should for patients who've undergone, complex pelvic surgery or radiation treatments to the pelvis that can have some, pretty significant kind of consequences, as far as pelvic health. But yeah, that's something that I've been happy to see one of the pelvic floor physical therapists who comes to join us at our tumor board pretty much every week, and so she's been wonderful, and we're trying to really increase the awareness of that, and hopefully encourage providers and patients to use that resource.
Great. And so I don't know if you're aware of, but for breast cancer patients, we have something called a surveillance program. Is kind of like what we see patients prior to surgery looking into just breast cancer related secondary lymphedema. So we see a lot of these patients as a baseline, and then we follow them 2 weeks post-op, and then we follow them all the way up to 5 years, a little bit more often during the first 2 years. But has been a lot of information, I believe, is endometrial cancer. Correct me if I'm wrong. Looking into if you have to remove any inguinal lymph nodes that can put all these patients on a risk for lower extremity lymphedema. So we really would love to try to develop some kind of a surveillance program the same way that we do with breast, which we've been doing our breast surveillance program for now, like maybe 10 years now, and it's super great. It's really, we can catch things so early on that we don't deal with these lymphedema issues anymore. Like we don't see these big arms any longer because we are able to catch on earlier, that we can reverse it. So we try to really see we can implement that as well with a surveillance program for lower extremity lymphedema, utilizing bioimpedance and all the equipment that we're using to identify those signs early on. So how many of those patients that you actually, with a lot of the surgeries you do, actually you do removal of the inguinal nodes, that you see any issues with swelling on their legs after work?
Yeah, no, that's a good question. And yeah, we see, a lot of the cancers that we treat surgically, we do sample lymph nodes in some capacity, right? So, for example, with uterine or endometrial cancer, we'll typically remove pelvic and periaortic lymph nodes. Ovarian cancer, similar distribution. Cervix cancer, also very similar. Cervix, pelvic, and sometimes periaortic lymph nodes. And really the ones that really involve the inguinal lymph are the ones that we worry the most about, like you alluded to, for lower extremity lymphedema. We see that more with vulvar cancers, where we're doing kind of inguinal lymphadenectomy. We've tried to mitigate that by being a little bit more selective, and I know the breast surgeons do the same thing, where instead of, in the past, we used to remove kind of all of the groin nodes, and that could be extremely morbid and have high rates of lymphedema. And now we can be a little more selective. We do lymphatic mapping and inguinal lymph node excision or sentinel lymph node excision, which is one or two lymph nodes for your audience that from each groin or one groin, and that decreases the risk but doesn't eliminate the risk. So yeah, certainly having a plan in place, a surveillance plan, I think would be extremely valuable for patients. Thankfully, vulvar cancers are certainly not as common as breast cancer, so we don't have as many patients as breast would in this situation. But I think that certainly for those who are facing a diagnosis of vulvar cancer and needing groin dissections, I think this would be a great resource and certainly something we would want to use.
Great, perfect. What are you feeling about topical estrogen therapy for postmenopausal symptoms on patients who have breast cancer or even ovarian cancer, right? Where they have to be kind of in, type of endocrine type of therapy.
Yeah, no, I think that's a question that we get asked a lot, and it's always a challenging subject because patients come sometimes with, a lot of these cancers are hormone sensitive cancers. So being very careful with the effects of hormones, systemic hormones on the impact and effects it can have on their cancer diagnosis. Obviously, we see things a little differently with topical estrogen therapy or vaginal estrogen therapy because it isn't as systemically absorbed. There is some, but not as much. And so, I usually counsel patients that for most cancers, gynecologic cancers at least, it's perfectly acceptable, especially if your symptoms are such that it's going to be useful. We see that a lot with patients who've had prior radiation therapy, who've had complex vaginal surgery, or need additional estrogen therapy for healing, because that can really help with healing from vaginal surgery or vaginal repairs. And so I think that is a useful addition to kind of helping patients with some of these symptoms. Obviously with some of the systemic estrogens, so like the hormone replacement, like oral therapies or transdermal therapies, we have to be a little careful with some of the cancers that we are facing. For example, the breast cancers that are, I think even if they're not estrogen receptor, progesterone receptor positive, we typically don't recommend hormone replacement therapy, systemic hormone replacement therapy for those patients. However, for most cervix cancers, that's usually acceptable, and same thing with most high-grade serous ovarian cancers. We tend to be a little bit more careful with low-grade serous ovarian cancers because they tend to be a little more hormone sensitive, and so we have to be careful with that. And then the same thing with advanced endometrial cancer. We generally tend to stay away from estrogen replacement therapy for those patients just because there's a higher risk, is to be more hormone sensitive and you can increase the risk of recurrence in that situation. But there have been studies looking at it in early stage endometrial cancer patients, which thankfully most endometrial cancer patients were diagnosed at an earlier stage, which is great. And it's technically considered to be acceptable in that patient population, just with the proper understanding of the potential risks and benefits. And so we usually counsel patients about that. But certainly vaginal estrogen therapy, I think, is very reasonable, specifically if you're having urogenital atrophy symptoms and just symptoms related to treatment effects like radiation. It can be very helpful.
Okay, well, that was very helpful. Thank you. What is a painful lesson that you learn along the way? Either, as you, Dr. Iglesias, being just a, family member or as a physician?
Yeah, no, I think that's a good question. I think that's always good to reflect back on things. Obviously in medicine, we're always confronted with scenarios that don't always have a clear black and white answer or yes or no answer. And so I can certainly think of scenarios that perhaps in hindsight, would I have done it something differently? And it's hard to know that because you don't have the benefit of the future knowledge. But so I don't try to, think too much into that because I go with, make the best decisions I can for the specific patient with the circumstances that are presented to me. I guess to answer your question, the thing I probably, in hindsight, I wish I would have maybe thought through differently was more of a personal thing. It's more kind of establishing appropriate boundaries, I guess, from a family work-life balance standpoint. I think that, a lot of us who go into medicine, in the field of medicine, we're very driven, we're very ambitious and focused on our careers. And that may be fine earlier on in your life when you're like single and you don't have any kids and all that, but as I've gotten older and had three beautiful children I love to death, I tried to do my best to be there for them throughout their lives and their different events. I probably could have done better in certain parts of my life, and so I think that in hindsight, those are the things that I wish I would have done a little bit differently. Potentially, been more present. I think that in this day and age when we're bombarded with electronic medical records and results that come in, at all hours of the day, and we're so accessible now that it's sometimes challenging to be present, in the moment. Even if you're physically there, are you mentally there? Those kind of things. So those are the things I think I would change if I could.
Yeah. And it's hard for all of us, right? Like sometimes I think that, during the pandemic, I think the one good thing out of the pandemic was to try to bring those values a little bit back, like when you're like everything is shut down, everything is closed, and then you're just looking at, all these lives that we lost, and we're like, man, how often are we really thankful for what we have here now and how much we take advantage of that because we don't know we're going to be here tomorrow, right? So sometimes you're right. And even happened to myself, it's like sometimes putting time on clinic and doing this and doing that. And then it's like at the end is is the kids, and my husband is like, okay, so how do we balance that? And it's hard. It's hard because you're passionate about something. You love them as much as you love this. It's like I wish
Yeah.
I had 40 hours a day, right?
Right, exactly, and I think that's I think a struggle for a lot of us, not just in medicine, but it's, I think a common problem, or struggle for a lot of people in society today, and so I think that just something everyone's grappling with. But I think that's the really I wish I could be more present when I'm there, when I'm physically there, mentally be present and focus on the scenario and what they're doing and what my family's doing. And but I think that's something I'm working on. So
Great. How can people find you? And I'll put those in the show notes so people can just find you that way. But where can they find you?
Yeah, so I mean, my primary practice is here in Gainesville at the UF Health Medical Plaza. I do see patients also in Ocala, the Ocala Heathbrook Clinic. I'm usually down there twice a month, so I see a lot of patients from the Ocala and the Villages area and Leesburg and things like that. So that's another good resource, and we're going to start. Me and my partners can start going down there a little bit more often. Right now, just twice a month, but we'll try and expand that presence a little bit as well. And then we also will start seeing some patients at Spring Hill office, kind of off 39th in Gainesville. But yeah, those are the three kind of locations that we see patients in the outpatient setting. I do the surgeries at the UF Health Shands Hospital, so here in Gainesville. Our clinic office number, you might have this on your notes here, but our clinic office number is 352-265-8200. So that's for the women's clinic at the Medical Plaza, and they can certainly connect patients and their providers to me and my team.
Perfect. Excellent. What are good resources for patients to use to educate themselves on gynecological cancer?
Yeah, I think this is so important because, obviously with the internet and all the resources available on the internet, it's very easy to kind of find things, but also kind of go down the wrong path or get a lot of information that might not be as accurate as it could be. So I always recommend for patients who are looking at a resource for women's cancers, there's a great organization called the Foundation for Women's Cancers.
Okay.
It's, I think, foundationforwomenscancer.org is the website. It's, I'm part of the Society of Gynecologic Oncology, which is the kind of national organization for gynecologic oncologists. The Foundation for Women's Cancers is like the patient-facing part of them. So they provide a lot of really useful information for patients. It's really kind of geared towards patient education, but also for providers. If there's a family practice provider, internist, general gynecologist, or anyone who's taking care of women, they can use these resources that are free, on there to have, valuable information about, what staging is like for ovarian cancer, what resources are available for patients. So that's, I think, probably the most useful, and it's very easy to read, but also most useful website that I found. Obviously, the American Cancer Society has a very good website that talks about all the different types of cancers. And there's also a lot of different foundations that have very specific, focuses. For example, one that I've worked with in the past, the Sandy Rollman Foundation for ovarian cancer, awareness. And there's other organizations like that one. But I think the Foundation for Women's Cancer, I think, covers the breadth of GYN oncology. So it talks about all the different gynecologic cancers that we treat, and really has some useful resources, and also can link out to other organizations that can provide additional resources as well.
Great. Is any podcast that you listen to that you would recommend to the audience?
Well, I guess medical podcast, I don't listen to too many medical podcasts, but I do listen to a few, just kind of non-medical ones. But I guess the ones I would recommend, there's one called, I'm a huge baseball fan. I love baseball, and it's like, that's been my passion since I was a kid. And so I just listened to a podcast called the Pausecast with Joe Posnanski. It's just a baseball, like, talks about baseball and just sports in general. But that one, and then I've really been listening to one recently about it's by Adam Grant, who's an author who talks a lot about organizational psychology, and his podcast is called Rethinking, and it's been really instrumental to me to kind of think through kind of what my thoughts are about specific things, and how do I, kind of talk about new thoughts, new ideas, and how to kind of maximize, my performance at work, but also those in my team, and how do we kind of grow together.
Mm-hmm. Yes, I heard about this one a while back from one of my guests, and I've been listening. It's pretty cool. I really like it as well. It's really nice ones. That has been enough. Is any other question that you would like me to ask, or something I did not ask you to wrap up?
No, I think this has been pretty great. I mean, I think it's been wonderful to be part of this, and it's been. I'm glad that we have someone like you who's hosting podcasts like this, just because I think it's a useful tool for providers, but also for patients and their families. And I think hopefully destigmatizes conversations about difficult topics. So I think it's important to just have this opportunity to share this information. I think that really the take-home message is just for all women who are going through symptoms and might be experiencing new changes to their body, just be open and have a dialogue with their doctors, with their primary care physician or nurse practitioner or gynecologist, just to kind of talk through some of these things, because I think one of the things we talked about earlier was some of the cancers that we treat, some of them have very easy to identify kind of warning signs, like vaginal bleeding when you shouldn't be bleeding after menopause, for example. But some of them are very kind of non-specific, very vague. Like for ovarian cancer, it's, the symptoms are so vague. It's nausea, vomiting, bloating, things that could happen just with GI symptoms. I have so many patients who I talk with who've been diagnosed with ovarian cancer who say, I didn't really know I had anything going on at all. It wasn't until after they were told they had a cancer because it was found for other reasons that they look back and say, okay, yeah, maybe I had some symptoms a few months ago. And it's just really hard sometimes to narrow that down. So if you notice a change, be open with your doctor about it. It sometimes can be, it can be anxiety inducing to bring things up like this, but I think it's important to just have, an open dialogue with your doctor and just be aware of the changes your body might be.
Yeah, and I'm so glad you actually mentioned that. Sometimes as a society, we're thinking, like, some amaze me again from the PTA standpoint, and I'm not a pelvic floor therapist, but know enough about talk that sometimes it's like no commercials about like pads, right? So pads are normal for you. If you're past whatever 60, here, go get these pads, and it's like, why are we telling patients like this is okay, right? Because it's not okay. You shouldn't have to wear a pad. I tell my mom, who is 83 years old, 81, I say, Mom, if you ever have to do that, you need to go see your gynecologist and talk about, sending you to pelvic health floor, because these things can be really done to help you with that. You don't need to do that, because if you go into that, that means now you're older and now you're going to end up to have more UTIs, which we know what that is going to take you to. So it's super important for for women out there to just say it. Don't feel embarrassed about it, right? And sometimes this is kind of like what sometimes in this area, they don't want to say, no, I have been pain with intercourse, right? Or I'm just really bleeding this way, because they don't, it's just such a private conversation that is hard for them to really open up. So it's super important for them to really have that kind of relationship with either their primary care physician. And I always say, always have a gynecologist, just so you guys are the specialists. So it's good to have that relation, even if you don't have to see you guys often, but you're there when you start having any symptoms at all that are really not normal.
Yeah, no, I agree. I think having that relationship is important, and the more often you see your gynecologist and have these kind of visits, they'll know what to ask you and talk about specific topics. You'll be more comfortable bringing up kind of conversations. You mentioned sexual health, and these are things that are not easy to talk about. No one really finds that easy to do. And so but the more the relationship you have with your physician or your nurse practitioner or your physician assistant who sees you on a regular basis, the more that you'll maybe more comfortable bringing that up and discussing kind of changes that you might have otherwise ignored, that could have be a sign of something else going on that might need further workup.
Yeah, and we actually come across again, we see a lot of breast cancer patients here, so is that conversation is on a daily basis. We again with this endocrine therapy throwing patients into menopause and having these menopause symptoms, and it's really hard, right? Like, how do I tell you? Yeah, I understand what you're going through, but it's something that you have to do for your breast cancer recurrence. But sometimes I say, go talk to your, medical oncologist or talk to your gynecologist and see if it's anything else can be done to mitigate some of those symptoms. And if you can and you're in totally misery, you may have to make a decision. It is worth it to really look into this endocrine therapy, and I'm just swing the risk of getting another breast cancer recurrence versus just living a horrible life day in and day out. And so quality life is so important. And sometimes we don't see that, right? Because we are not in those patient shoes. So it's hard for us to just kind of like, what else can I recommend you to do besides doing that to help with that? We know like vaginal estrogen is a great alternative for some of these symptoms. And we talk about aquatic therapy for some of those joint pains they're having, and exercise and eat better. But it's so hard to really help these patients when they go through all those symptoms.
Sure. Yeah, I agree. And another also topic that comes up that can sometimes be pretty challenging is we are seeing more and more patients now diagnosed with cancers at a younger age where they may not have finished childbearing or completing their families, and so these are oftentimes difficult conversations and topics, and I think it's important for your audience to know that sometimes there are ways we can preserve fertility for treatments of some of these cancers. Even though it might not seem like that would be feasible, there are ways we can at least kind of talk through options in those situations. And at the very least, kind of get patients kind of plugged in with a great oncofertility clinic here. So for men and women who are facing a cancer diagnosis and have questions about fertility potential and how to preserve as much of that as possible, there's a clinic here that and a team that helps with that. So they work with us on our patients as well. And so I think that these are always challenging and can be very emotionally heavy conversations, and I think are important conversations to have nonetheless, especially when someone's facing a diagnosis and we're trying to think through a treatment plan that makes the most sense, that's effective, for treating the cancer, but also aligning with their goals.
I'm so glad you mentioned that, and I'm so glad you do that as well from the gynecological standpoint. Dr. Spiegel, our breast surgeon, she is great about thinking about all those options. So usually, when somebody who is young, it's usually a consult with fertility, if that's something, at least is mention it to the patient so they can explore that. So I'm so
Yeah.
glad that you guys doing that as well, because it's important. Sometimes again, you have somebody who is young and then just facing the cancer world, and that's the last thing they worry about is in the future to have a baby. But it is so important for them to take that right then before they start any treatments, right? So
Yeah. And just to be aware that there are sometimes options. Sometimes we don't have all the options, but I think that it's at least worthy of a conversation to make an informed decision, so that way they know the impact that whatever treatment we're going to be recommending might have on their body and their future, and so I think that, I think just as part of being, an informed patient and making, informed decisions about your healthcare.
great. That was amazing, Dr. Iglesias. Thank you so much for spending all this time and give us such a great amount of information. That was really helpful.
Yeah, you're welcome. It's wonderful. Thank you for the invitation.
Absolutely. You have a great evening.
All right. Thanks.